Of course. So, hello everyone. My name is Jessica Eccles, and I am a brain-body neuroscientist, and I've been working with my former PhD supervisor, Professor Neil Harrison, on what I think and we think was a very ambitious project to characterize why people may be more vulnerable to pain and fatigue. We initially conceptualized it as a study where we would see whether pain and fatigue was altered by an inflammatory challenge and also an autonomic challenge, to see the contribution of inflammation and changes in autonomic function to symptoms. And we conceived it as having four groups. So healthy controls, patients with pain predominant disease, which we anticipated recruiting from fibromyalgia populations, patients with fatigue predominant disease, which we anticipated recruiting from ME/CFS populations, and then a mixed group with both pain and fatigue. And we were going to compare the differences. But as I talk you through, we'll see that didn't quite happen. But the project, which has been funded by Versus Arthritis and Action for ME with support from the Fibroduct Foundation, we have completed data collection, and we have some really exciting initial results. So I'm going to talk you through that. So these slides are a collaboration between myself and Professor Neil Harrison. And so many of you in the room will have already pondered this. Is inflammation or infection a precipitant in ME/CFS? That's a very important question. We know that for people meeting caseness for ME/CFS, that fatigue can persist for a long time after the initial infection, and these are various different viruses that have been shown to be associated with fatigue. The little diagram on the right shows that symptoms persist for a long time after illness. However, there is a bit of a mismatch in that this is not necessarily reflected in baseline inflammatory responses. So what we're thinking in our minds is it the baseline inflammation that's important, or is it the change in inflammation that is induced by an infection or an inflammatory challenge that is important? Okay, so what we're wondering is, why do symptoms in ME/CFS develop and persist? Is the immune system somehow hyperreactive to subsequent inflammatory challenges or autonomic challenges? Does the brain become hyperreactive to subsequent challenges? And is there dysregulation in how the immune system and the brain are talking to one another? So this is one of Neil's slides. It's basically saying that we're exposed to pathogens. These activate things in the body, pattern recognition receptors, the PRRs, and then there is a whole very complicated immune response which leads to sickness behaviors. And so these sickness behaviors we're all familiar with from having the flu, but some people who are affected are familiar with them every day. So these are things like feeling persistently fatigued, wishing to isolate, having psychomotor retardation, which means slowing down, and being hypersensitive. And we know that these are related and can be induced by giving people cytokines, and they lead to all of the things in this little graph. And Neil has really pioneered trying to study the mechanisms of that by using something called LPS, which stimulates the immune system, and also typhoid vaccination, which induces a very mild inflammatory challenge. We also have evidence from patients with inflammation. So people with hepatitis C used to be treated with an inflammatory cytokine called interferon alpha, and this led to fatigue, low mood, sickness behaviors. We also know from the arthritis population, if you use a biologic, you may improve both pain but also fatigue, and also, interesting from my perspective, may have an impact on mood symptoms as well. So Neil has led on looking at how cytokines actually act on the brain. It was thought when I was at medical school that the brain was an immune privileged site, and that peripheral inflammation didn't get into the brain. We know that that is not the case. If you give rodents something called CFOS, there is a brain response within minutes to hours. Neil has done a suite of very sophisticated imaging work showing with functional MRI and PET and another type of imaging called QMT that inflammation induces changes in activity in a part of the brain called insula. Now, the insula is very important for our representation of our own internal bodily state. So pretty much all of our internal experiences may be represented there in insula. And I will touch on this a little later in terms of how it may relate to our sensitivities and sensibilities to interoceptive processes. So this is just some more imaging from Neil, again highlighting across several different imaging modalities the absolute importance of insula and how activity in insula in these different imaging modalities correlates with change in symptoms induced by inflammation. So, and then this is other work about interoception by Craig, showing the insula again and again in a variety of interoceptive moments. So this is being experienced to pain, chronic pain, certain types of touch, exercise, itch, cold. They all seem to activate this part of the brain. So, apologies, there's a growing consensus that ME/CFS and perhaps fibromyalgia may be illnesses triggered by infection, which release cytokines and act on the brain to trigger flu-like symptoms and malaise. And we know that physical, immune, and cognitive stressors all trigger cytokine release, and they can all cause severe exacerbation of symptoms in patients with ME/CFS or fibromyalgia. So, do people with ME/CFS and fibromyalgia show a greater and more persistent inflammatory response to stressors, such as an immune challenge? And is the brain more sensitive to these stressors? And can we measure this in terms of brain function, connectivity, and markers of inflammation in the brain? So this study, which I'm just having a little sip of water, this study, which we first thought about in 2016, I think, and has only recently finished data collection. It was in 2 phases. So well, 3 phases really. We screened patients. I think we screened over 200 potential participants, and we characterized whether they met diagnostic criteria for ME/CFS using the Canadian criteria and the Fukada criteria. We also used the ACR criteria to see whether they had met diagnostic criteria for fibromyalgia. We brought them into our hospital, Brighton and Sussex University Hospitals Trust, where we measured their baseline pain and fatigue, and we put them on a tilt table. And then we measured pain and fatigue again whilst on tilt. Tilt is a challenge to the sympathetic nervous system. We also were able, because we were in the hospital, we took baseline markers of inflammation, the type of thing that a GP might ask for, such as CRP and ESR. We then, in the next stage of the study, participants came to our brain imaging centre on 2 occasions. One time they had pain and fatigue measurements and then had a saline injection. On the other time, they had pain and fatigue measurements and had an injection of typhoid vaccination. They then waited a little while and they had brain imaging and inflammatory cytokines and further measurements of pain and fatigue. So these are the 2 different things, the autonomic challenge and the inflammatory challenge. And thank you so much to all of the participants who, although affected by pain and fatigue, stuck with us and were able to complete the study. In terms of our recruitment, we actually had about 105 people take part in total. In terms of the data that is analysed, we have 65 patients who either have a diagnosis of ME/CFS or fibromyalgia or both, and 25 healthy controls. And for anyone who's interested in, reading a little bit more about the protocol of the study, that is the link to the trial registration. It is not a clinical trial, it is a study, but the inclusion and the exclusion criteria are available on the internet. So as I mentioned before, they all underwent research diagnostic evaluation. They all had an autonomic challenge, and the majority completed an inflammatory challenge. Occasionally that wasn't possible due to factors. Sometimes we did find in a few patients connective tissue abnormalities in the brain that meant that they were no longer suitable to take part. Next slide. Now this is an interesting finding, and I'd be interested in other people's thoughts as to what to make of this. So of those enrolling in the study, about a third had a clinical diagnosis of fibromyalgia, a third had a clinical diagnosis of ME/CFS, and a third had both diagnoses clinically. When we looked at the research evaluation, in fact, almost all of the participants met diagnostic criteria for both diseases. Now, we can't tell from this, do they actually have both diseases? Or is there a function of the way the diagnostic criteria work that mean that they overlap and cannot distinguish between the two? So I think that's an important question for discussion. For any of you that follow me on Twitter, I'm at BendyBrain. I am interested in variant connective tissue, and that is often talked about as joint hypermobility. We found a very interestingly high number of participants with what we would conceive of as symptomatic joint hypermobility. So 81% of the patients and 40% of the controls. And what was interesting, and quite a few meeting the very strict hypermobile Ehlers-Danlos syndrome criteria, and that the historical degree of joint laxity, but not the current degree of joint laxity, predicted fatigue impact, total pain, somatic symptom severity, and also the degree of which someone is aware of their own internal bodily sensations. If you are more interested in reading more about this overlap and the controversies within this overlap, because it's a very controversial field, we have pre-printed our findings, and if you just Google medRxiv Eccles, it will come up. We're in the process of submitting for peer review at the moment. But what's really interesting is there was another paper come out of Denmark, exactly the same rates of hypermobility when we analyze the data in the same way, looking at 200 ME/CFS patients and the importance of craniocervical instability. Anyway, headline findings so far. So if we look at the simple blood tests that GPs can order, this is something called the erythrocyte sedimentation rate, ESR, often raised in inflammatory rheumatological conditions. We find that the patients who have either ME/CFS or fibromyalgia have significantly higher baseline ESRs than controls. What's interesting about this, though, is although it's higher, it's technically within the normal range. But as I will explain to you later, this variation within the normal range predicts all sorts of symptoms. So although we're not saying that due to typical classical pathology guidelines, these patients have a clinically significant ESR, it is indeed greater, and the variance in that degree of difference explains symptoms. We also found, and another group has recently reported differences in high sensitivity CRP in patients with fibromyalgia and ME/CFS compared to controls. We didn't find that it met the kind of diagnostic level, but there was definitely a trend for greater CRP in patients compared to controls. And Neil and I, before he left Brighton to go to Cardiff, Neil set up an immunopsychiatry clinic in Brighton, where we see anyone with a CRP of 3 or more, because we know that people with a CRP of 3 or more respond differently to different psychiatric medications, including different antidepressants. So noradrenergic ones seem to work better if you have even just a tiny raised CRP. So this is also really interesting, and this is spearheaded by our Action for ME funded PhD student Marisa Amato. She's done cytokines on IL-6, which is an important pro-inflammatory cytokine, and we find clear difference between patients and controls in their baseline levels of IL-6. Now, when we look to see what happens to the IL-6 when you induce inflammation, so i.e. with typhoid vaccination, not the typhoid, the disease, when we don't see any really striking group differences. But if you dig into the data further, there are some absolutely fascinating, and probably the subject of another talk, differences related to variant connective tissue, so some of the hypermobility markers that really do predict this change. Okay, now this is, I think, really fascinating, and we really hope to get this information out to the general medical and patient world, is that just your baseline level of inflammation, which is technically within the normal range, predicts all sorts of things if you have ME/CFS or fibromyalgia. So the baseline ESR predicts baseline pain, fatigue severity, fatigue impact, and then fascinatingly, the change in fatigue induced by the autonomic challenge. So the higher your baseline ESR, the more pain response you have to an autonomic challenge, fatigue response, sorry, and the more pain response you have to an inflammatory challenge. So it's similar but different results with CRP, baseline pain score, fatigue impact, and change in pressure pain thresholds induced by tilt. And I can't actually see under my slide, but baseline IL-6 is associated with baseline pain, and also I think it's either change in pain or change in fatigue induced by tilt. But the next slide will make that clearer. So what we find is on the left-hand side, so the y-axis, we have change in self-reported mental fatigue, so kind of brain fog symptoms after the inflammatory challenge, correlates very nicely with your baseline cytokine IL-6. Same thing with inflammation-induced change in self-reported pain, correlates with how much your cytokine changes with inflammation. Okay, so this is just the basic stuff. What Marisa Amato, our PhD student, is going to be spending the next 9 to 12 months before writing up her PhD is doing some really fascinating brain imaging analyses using the fine-grained approach afforded by the Human Connectome project. So we don't yet have any actual brain imaging data to present to you, but we will be doing functional brain imaging, structural brain imaging, resting state brain imaging, and a marker of inflammation called QMT, and a diffusion marker called NODI. So there's lots of exciting brain inflammation data to explore. And this is just how the maps are going to look, and they're going to be very pretty. So just to recap, I've probably taken less time than I needed, but I'm just going to tell you the key findings already, which is we've got a significant cohort of patients and we have a significant number of controls. We know that ME/CFS and fibromyalgia, according to diagnostic criteria, and is my experience in talking with patients that pain and fatigue are very comorbid, are more comorbid than possibly previously thought, and appear to be associated with variant connective tissue, which may be manifest as joint hypermobility. ME/CFS and fibromyalgia are associated with higher baseline inflammatory markers, but our analyses also need to take into consideration other individual variables. So this would be things like the contribution of body mass index to inflammation. We also know that pro-inflammatory markers at baseline are associated with a number of important symptom scores, including pain, fatigue, and fatigue impact, and that these pro-inflammatory markers predict sensitivity to the autonomic challenge and the inflammatory challenge. We know that on a group level, ME/CFS and fibromyalgia per se are not associated with significant increased peripheral IL-6 responses, but there are significant individual differences that may better explain this picture. So I think I'm really pleased with the results of the study so far, and why it is important is that I think having a better understanding of the mechanisms, by being able to say this is related to inflammation, this is related to autonomic dysfunction, these provide us with treatment targets. So we know that potentially there are medicines that could be repurposed, or there could be conditions within this population, such as underlying orthostatic intolerance, that could be targeted potentially to help relieve symptoms. I also think it's important for the general recognition of the science in ME/CFS and fibromyalgia, that these biological mechanisms are better understood. So we have a lot more work to do. I mean, I have a little kind of project management board, and we are looking at about 15 different papers to come out of this study. I haven't even talked about some of the very weird and interesting findings that we've found about interoceptive differences or ADHD subscores or things like that, but there is lots of fascinating data out there. We need to complete the MRI analyses, and Marisa will be working closely with colleagues in transcriptomics. We have transcriptomic data after saline and transcriptomic data after the inflammatory challenge. So what we'll be able to do, and I think for the first time ever actually, is look to see differences in gene expression that are induced by inflammation. So not just baseline differences in gene expression, but actual changes in real time induced by inflammation. And I think we know from genetic work that we're not going to find a clear gene of difference, but how genes are expressed in response to such challenges may prove fascinating. So a big thank you to all of the funders. So this is Action for ME versus Arthritis. We've been supported with additional help by the Fibroduct Foundation, and my salary throughout has been supported by the National Institute of Health Research. We want to say a massive thank you to all of the participants and research staff who helped contribute to this study. I totted it up in my notebook the other day, and I think we're talking about 1,300 hours of testing, with probably another 200 to 300 hours of screening alone. We are really thankful to our patient support organisations who have helped facilitate recruitment. So that's the Sussex ME/CFS Society and Remember, the medical school and the hospital, our postdoctoral research fellow who coordinated this whole project, Dr. Christy Themelis, Marisa Amato, our PhD student, our collaborators, Professor Kevin Davis, and also my rheumatology collaborator, Charlotte Thompson, who has helped analyse this data.